Sunilji.
We are like,
A very warm welcome to iFocus Online Lecture 510, the second in Eye in Systemic Diseases. Today we have none other than Dr. Abhilasha Baharani to teach us on eye in rheumatological and collagen vascular diseases. She's completed her MBBS from Kasturba Medical College, Manipal, Karnataka, her DNB Ophthalmology from Arvind Eye Hospital, Tirunelveli. She's also done her FRCS Glasgow and FICO from UK. She has a fellowships in uveitis and ocular inflammation at Arvind Eye Hospital, Madurai, and ocular inflammatory disease and vitreoretinal disorders at the Royal Victoria Eye and Ear Hospital, Dublin, Ireland. She's currently the clinical head, senior consultant, and uvea specialist from the NeoRetina Eye Care Institute, Hyderabad. She's the editor-in-chief of USI Newsletter. She's the member and South Zone representative of the Uveitis Society of India. She's won several awards, including the Carl Herbert Award at the USI annual meeting in Bhubaneswar. She's also received the Award of Distinction and Award of Merit at the International Ophthalmology Conference for Innovations and Challenges in Glaucoma and Uveitis in Singapore. She's won the Best Poster Podium Presentation Award at UVIA at AIOC 2019 and 2023. She has several research articles in reputed national and international peer-reviewed journals. We're very glad to have you here, ma'am. Over to you.
Thank you so much for the kind introduction, Dr. Ashwita. I'll just share my screen. At the outset, I'd like to congratulate Dr. Mahipal sir and Dr. Santosh Honavar for the grand success of iFocus. And it is very heartening to see that this is the 510th lecture. I'm very fortunate, and I would like to thank Dr. Partho for this kind opportunity. So I'll be speaking on eye as a window to rheumatological and collagen vascular diseases. Classification of rheumatological and collagen vascular diseases. So autoimmune connective tissue diseases are characterized by autoantibody production, immune complex deposition, and multi-organ involvement. In this lecture, I'll be covering systemic lupus, erythematosus, rheumatoid arthritis, and systemic sclerosis. Seronegative spondyloarthropathies are characterized by the biaxial involvement, HLA-B27 association, and absence of rheumatoid factor. That is why these diseases are called seronegative, because they are negative for rheumatoid factor. Coming to the diseases. Yeah, so in this talk, I'll be covering the ocular association of ankylosing spondylitis. Coming to the vasculitis or inflammation of blood vessels, these are grouped by the vessel size involvement. So large vessel vasculitis is seen in giant cell arteritis, Takayasu arthritis. Medium vessel vasculitis is seen in polyarteritis nodosa and Kawasaki disease. Small vessel vasculitis is seen in granulomatosis with polyangitis, which was formerly known as Wegener's granulomatosis. Microscopic polyangitis, Church-Strauss syndrome, and Henoch-Schönlein purpura. In this section, I'll be covering Takayasu arthritis and GPA. Now, these crystal-induced arthropathies and autoinflammatory syndromes do not have significant eye associations, so I'll be not covering them. Coming to pediatric rheumatological diseases, in this lecture, I'll be talking about juvenile idiopathic arthritis, which is the most common form of pediatric uveitis. So the first disease is systemic lupus erythematosus or SLE. It is a chronic multisystem autoimmune disease characterized by the production of autoantibodies targeted against components of cell nuclei, immune complex deposition, and inflammation that can affect virtually any organ system. Now, the etiology and risk factors are multifactorial. There is genetic predisposition. The triggers are UV light, infections, most importantly, viral infections. So viral infection can actually uh, 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 change the composition of the DNA, which can actually not be recognized by the immune system. And that is how you get autoantibodies against the cell nuclei. Again, smoking and certain drugs can also trigger. There is a clear female predominance of 9:1, especially in women of childbearing age. Now, pathophysiology, there is loss of self-tolerance, and that leads to autoantibody formation, especially anti-nuclear antibodies, that is anti-dsDNA and anti-Smith antibody. Immune complexes are deposited in tissues, leading to complement activation and inflammation and damage. This is a type 3 hypersensitivity reaction. Now coming to the classification criteria. Now the EULAR ACR 2019 criteria, the entry criteria is ANA positivity. So if ANA is positive, only then you can proceed. The other domains are constitutional symptoms like fever, hematological problems like leukopenia, thrombocytopenia, autoimmune hemolysis, neuropsychiatric problems like delirium, psychosis, seizures, mucocutaneous like a non-scarring alopecia, and malar rash, which is very typical, cirrhosis, mucoskeletal, and renal problems like proteinuria and lupus nephritis. The other things that can be scored are antiphospholipid antibody, low complements, low C3 or low C4 or both, and SLE specific antibodies, as I said, anti-dsDNA or anti-Smith antibody. Now, classification threshold, the entry criteria is positive ANA. Total score required is more than 10, and we have to use the highest score per domain and must include at least one clinical criteria. So, as ophthalmologists, we should know the diagnostic criteria so that we can take appropriate history and look for systemic signs in these patients. The most common eye manifestation is dry eye syndrome, which occurs in 20% patients with SLE. So, if you see a patient who is complaining of dryness, burning, foreign body sensation, photophobia, always keep SLE in mind, especially in females of childbearing age. Don't just write lubricating eye drops and send the patient away. Sometimes systemic uh, evaluation helps in treating these patients. Episcleritis and scleritis. Episcleritis is generally mild and self-limiting. Scleritis is more severe, painful, and can lead to visual loss, and usually it is non-necrotizing. Okay, so SLE scleritis is non-necrotizing. Coming to retinal involvement or lupus retinopathy, this can be a marker of systemic disease activity. The prevalence is 3 to 29%. The typical signs are cotton wool spots, which is the classic lesion, retinal hemorrhages, arterial narrowing, and vascular occlusion. In severe cases, there might be retinal vasculitis with proliferative retinopathy. Optic nerve involvement can be seen as optic neuritis or ischemic optic neuropathy. Choroidopathy is may cause serious retinal detachment and is often associated with hypertension or renal disease in SLE. Orbital involvement, there might be orbital inflammation or myositis, which can mimic thyroid eye disease. Now, this is a patient who presented with decrease in vision in her left eye. And till now, she was not diagnosed as a case of SLE. So here you see the cotton wool spots. These are flame-shaped hemorrhages. And this is dilated, engorged retinal veins and narrow arteries. You can see the narrow arteries. On OCT, there is inner retinal hyperreflectivity and subretinal fluid. So this patient had a combined hypertensive plus SLE retinopathy, because you also see a disc edema and AV crossing changes. And on starting treatment, patient was put on systemic immune suppression, but she still had a pale disc and retinal thinning. Coming to rheumatoid arthritis. Rheumatoid arthritis is a chronic systemic autoimmune disease that primarily affects the synovial joints, causing inflammation, pain, and progressive joint destruction. Can also involve extraarticular systems like eyes, lungs, skin. The etiology and risk factors. It is an autoimmune process with unknown cause. There is a genetic predisposition. So environmental triggers are smoking. This history is very important, and there is, of course, a female to male ratio is 3:1, usually between ages 30 to 50. Um, Articular symptoms, patients have symmetrical joint involvement. Small joints are involved first, and there is morning stiffness for more than 1 hour. So, if you see a patient with dry eye, scleritis, episcleritis, always ask for history of morning stiffness. We generally just tend to ask whether there is history of joint pains. But before the patient gets pain, patient might be having morning stiffness, and this history should be asked. There is joint swelling, tenderness, and warmth. And in late stages, there might be deformities like swan neck and ulnar deviation. Now, the ACR-ULR criteria for classification of rheumatoid arthritis, this you can read up, and it is good to know the diagnostic criteria. These are generally used for research purposes, but for clinical uses also, it might be useful, and I think you can read this up. Now, the eye manifestations of rheumatoid arthritis, again, dry eye syndrome is the most common ocular manifestation. It is caused by secondary Sjogren syndrome. Episcleritis is inflammation of the episclera. The symptoms are mild pain, redness, and tearing, and usually it is self-limiting and benign, and it correlates with disease activity. So in rheumatoid arthritis, generally, if the eye is involved, the eye is not usually the presenting sign. In rheumatoid arthritis, patient will have systemic disease. Uh, Dry eye might be the presenting sign of rheumatoid arthritis, but generally, episcleritis and scleritis show that the systemic disease is severe. Scleritis is serious and vision threatening and can be diffuse, nodular, or necrotizing. So in SLE, it was usually non-necrotizing. In RA, it is necrotizing. And symptoms are severe pain, which often radiates to the head. Necrotizing scleritis is most severe, and it is strongly associated with severe systemic RA. Coming to PUK, it is rare but a severe manifestation. It is often associated with scleritis. There is risk of corneal thinning and perforation, and it is also a sign of high systemic disease activity. So, episcleritis, scleritis, and PUK signify high systemic disease activity. Now, this is a patient who presented to me with bilateral diffuse anterior scleritis. And this is an early case. I think patient did not visit the doctor for a joint pain. She was just taking painkillers. But here the knuckles are thickened and they were tender when she came to me. So this is how an early case might present. And this is a very late case. You see the joint deformities and the PUK, the cornea has ruptured and there is iris prolapse. So it can be that severe. Coming to the next disease, that is systemic sclerosis, also known as scleroderma. It is a multisystemic connective tissue disease characterized by severe alterations in the microvasculature, inflammatory and immunologic alterations, and excessive deposition of collagen and other intracellular matrices in the skin and internal organs. There are two types, limited cutaneous and diffuse cutaneous. In limited cutaneous, the skin thickening is limited to the distal extremities. It is associated with severe pulmonary hypertension with anti-centromere antibody positivity. In diffuse cutaneous, as the name suggests, there is widespread skin thickening and there is even the trunk and proximal limbs are involved. There is early visceral involvement and there is a risk of severe retinal disease, and this is associated with anti-topoisomerase antibody. The clinical features are thickening and hardening of the skin, that is sclerodactyly, tight, shiny skin, that is mask-like faces, digital ulcers, telangiectasias, and calcinosis, and Raynaud's phenomenon, which might be the initial sign. Now, the vascular features are Raynaud's phenomenon, nail fold capillary abnormalities. This is also used in studying the retinopathy that is associated with scleroderma, pulmonary arterial hypertension. Gastrointestinal patient always ask history of dysphagia and reflux. And so these systemic signs might be useful for us to know so that we can diagnose these cases. Pulmonary patient might have interstitial lung disease, especially in diffuse cutaneous type, and pulmonary hypertension more common in limited cutaneous type. Renal, there might be scleroderma renal crisis, sudden hypertension, and acute renal failure. A patient might also have arthralgia, myopathy, and contractures. So this is the ACR-ULR classification criteria for systemic sclerosis. So skin thickening of the fingers of both hands extending proximal to the metacarpophalangeal joints. So this itself carries 9 points. Then skin thickening of the fingers, fingertip lesions, telangiectasia, abnormal nail fold capillaries, pulmonary arterial hypertension and or interstitial lung disease, Raynaud's phenomenon, and scleroderma related antibodies. So patients having a total score of 9 or more are being classified as definite systemic sclerosis. So eye manifestations, dry eye is common. There might be periorbital skin tightening leading to lid dysfunction, conjunctival telangiectasia. Episcleritis and scleritis is not very common. Retinal microvasculopathy and optic neuropathy are very rare. But I'll show you a case of retinal microvasculopathy and optic neuropathy. So this patient presented with decreased vision in both eyes. And she said that she's not seeing clearly for 6 months to 1 year. And here you see that the disc looks a little pale. There are telangiectatic vessels and there are hypopigmented spots in the posterior pole. On fluorescein angiography, you see the hypopigmented spots are isofluorescent, and you see that there is leakage from the telangiectatic vessels. There is leakage from the retinal vasculature, and there is choroidal ischemia. These dark areas are areas of choroidal ischemia, and here you will see that there is leak from the disc as well as the vessels, and there is staining of those hypopigmented spots. Now, if you see, there is thickening of the skin proximal to the metacarpophalangeal joints, and you see the skin is shiny. There is loss of distal pad of fat. There is a pad of fat at the fingertips which is absent. There are hypopigmented macules on the skin, and these are drusen-like deposits. Those hypopigmented spots are drusen-like deposits. And after on starting treatment, the vision improved slightly, but there is a disc pallor and therefore there is field loss as well. So this is a very rare case of retinal microvasculopathy with optic neuropathy and requires a high index of suspicion in such cases. Coming to the next disease, that is ankylosing spondylitis. Ankylosing spondylitis is a chronic inflammatory disease that primarily affects the axial skeleton, especially the sacroiliac joints and spine, leading to progressive stiffness and fusion of the vertebrae. It is the prototype of the seronegative spondyloarthropathy. Okay. So onset is usually in males less than 40 years, and there is a strong genetic link. These patients are HLA-B27 positive, 90% of them. So there is chronic inflammation at the entheses, that is sites where ligaments and or tendons attach to the bone. This leads to ossification and eventual fusion of spine and sacroiliac joints, causing the stiffness, and it is driven by cytokines. So clinical features are chronic inflammatory back pain. So insidious onset before age 40. Now here also morning stiffness. In rheumatoid arthritis also there was morning stiffness, but that was of the small joints. Here, morning stiffness is of the back and it improves with activity. There is pain at night. Sacroiliitis leads to pain in buttocks, alternating sides, and there is progressive spinal stiffness, eventually leading to kyphosis. Peripheral involvement may be asymmetric, and enthesitis might lead to heel pain. Extraocular features, in the eyes, about 25 to 40% may have anterior uveitis. Patients might have aortic regurgitation, conduction defects, restrictive lung disease associated with IBD and with psoriasis. So it is when you see a case of HLA-B27 positive anterior uveitis, it is important to know these other features also, so that if you have a suspicion, you can refer to the concerned specialist. On X-ray, patients have bilateral sacroiliitis, which is an early finding, bamboo spine during the late stage. On MRI, you can see early sacroiliac joint inflammation. Now, this is my patient. You can clearly see the kyphosis. So the patient cannot straighten the back. So this is how you can, on clinical examination also, you can suspect the disease. Coming to acute anterior uveitis, it is the most common ocular manifestation of ankylosing spondylitis, seen in 25 to 40% patients. It is acute, unilateral, non-granulomatous anterior uveitis with significant protein extravasation with fibrin and hypopyon. It is recurrent, about 0.6 to 3.3 attacks per patient per year and alternating between the two eyes. It often precedes or parallels systemic disease flares. So if a patient has anterior uveitis, you can suspect that the patient might get back involvement soon, and therefore you must refer to the rheumatologist. It has a predilection for young males. About 49 to 84% patients with HLA-B27 positive anterior uveitis have an associated systemic disease. About 12% patients with HLA-B27 positive anterior uveitis develop SPA after 9 years of follow-up. So even if the case is in remission, patient should be followed up. Patient should be given a time to come back again. Then, presence of anterior uveitis does not correlate with severity of spondylitis. Now, these are some cases. Here in the first patient, you see there are non-granulomatous KPs. And here the patient has hypopyon with fibrin. This is again, you can see on this thing, you can see the non-granulomatous KPs. Here there are pigment deposits on the lens capsule from previous uveitis attacks. And here, this is a case of chronic uveitis. Sometimes patients present late or are lost to follow-up, and they might come later with chronic uveitis as well. Coming to Takayasu arthritis, this is a chronic granulomatous vasculitis that primarily affects the aorta and its major branches. So this is a large vessel vasculitis leading to arterial stenosis, occlusion, or aneurysm formation. It affects young women with higher prevalence in Asia, especially Japan, India, and parts of Latin America. Female to male ratio is 8 to 9 is to 1. Exact cause is not known. This is an inflammatory response. There is granulomatous inflammation of vessel wall leading to fibrosis, stenosis, and aneurysm. It targets the large vessels like aorta and its branches. So this is a biphasic disease. The systemic phase is characterized by fatigue, fever, night sweats, weight loss, and arthralgia. Occlusive phase, there is vascular symptoms due to stenosis, leading to claudication, reduced pulses, and blood pressure asymmetry. I will explain this. Now, the classic signs are depending on the system that is involved. So there might be absent or weak peripheral pulses or bruit. Now, interarm difference of more than 10 millimeters mercury in blood pressure. Patients might have dizziness, visual disturbances, aortic regurgitation, hypertension from renal artery stenosis, arm claudication, and limb ischemia. Diagnosis is based on elevated ESR and CRP. Inflammatory markers are raised. Patients are usually negative for autoantibodies like ANA and RF. So basically, this is a diagnosis of exclusion. On MRA, you can see vessel wall thickening. So when you are suspecting Takayasu, because the patient might be having a young female might come to you with saying that she is having TIA, transient ischemic attacks. She's not able to see. There are sudden blackouts. You can check blood pressure on both the arms, and if you suspect Takayasu, you can get MRA and look for vessel wall thickening, stenosis, aneurysms, CTA for luminal narrowing, wall enhancement, and conventional angiography is the gold standard, but it is invasive. PET-CT can detect early active inflammation. Classification criteria requires more than three of the following: age of onset less than 40 years, claudication of extremities, decreased brachial artery pulse, 10 millimeter difference in systolic BP between arms, bruit over subclavian arteries or aorta, and abnormal arteriogram, stenosis or aneurysm. Now, ocular manifestations mainly result from chronic ischemia due to involvement of the aortic arch branches, particularly the carotid and ophthalmic arteries. They may reflect early or advanced disease, and in some cases, may be the presenting feature. So sometimes it might be the presenting feature. So that is why it is very important to suspect this disease, especially in patients who are complaining of transient blackouts. So visual disturbances are the most common ocular complaint due to hypoperfusion of the optic nerve or retina and may be transient or persistent. Retinopathy or Takayasu retinopathy is seen in 20 to 30% of patients and graded in severity as grade 1, dilatation of small vessels, grade 2, AV anastomosis, grade 3, microaneurysms and hemorrhages, and 4, ocular ischemia and neovascularization, which is vision threatening. There might be hypertensive retinopathy due to renal artery stenosis causing secondary hypertension, and the features are arteriolar narrowing, cotton wool spots, flame-shaped hemorrhages, and papilledema in malignant cases. Anterior ischemic optic neuropathy, sudden painless monocular vision loss with pale swollen optic disc on fundus exam. Ocular ischemic syndrome, which is painful vision loss with neovascularization of the iris, retinal hemorrhages, and anterior chamber inflammation. Now, this patient came with painless loss of vision, and you see the severe ischemia in the retina. You don't see any blood vessels there. So on examination, and this such a stark picture, we got the blood pressure checked, and there was about 20 millimeter difference between the two arms. And later she was referred for treatment, but of course the vision did not improve. Even on OCT angio, you see that the superficial capillary plexus, you don't see any vasculature, any retinal vasculature. So this is Takayasu retinopathy. Coming to GPA, previously known as vaginous. GPA is a rare necrotizing granulomatous vasculitis that affects small to medium-sized blood vessels, primarily involving the upper and lower respiratory tracts and kidneys. So onset is typically between 40 to 60 years, slight male preponderance, more common in Caucasians. Autoimmune vasculitis is a granulomatous inflammation in the respiratory tract, necrotizing vasculitis of small and medium-sized vessels, and glomerular nephritis in kidneys. It has a strong association with C. ANCA. In upper respiratory tract, patient can have chronic sinusitis, nasal congestion, nasal septal perforation or saddle nose deformity, otitis media, hearing loss, and nosebleeds. Lower respiratory tract involvement, patient might have cough, hemoptysis, pleuritic chest pain, pulmonary nodules, and alveolar hemorrhage. Renal, patient might have hematuria, proteinuria, rapidly progressive presenting glomerular nephritis may lead to renal failure. So the diagnosis is based on C-ANCA positivity, which is positive in about 90% of generalized cases, elevated inflammatory markers, RBC, CAS, hematuria, proteinuria, and normocytic anemia and leukocytosis. Biopsy can be done to confirm the diagnosis. When you see necrotizing granulomatous, might show mucosal thickening and bone destruction. Coming to the ocular manifestations, so scleritis, episcleritis are the most common ocular manifestation, which might be diffuse anterior, nodular, or necrotizing. So when you see a patient with episcleritis, scleritis, and you should ask history of nasal congestion, sinusitis, so that sometimes scleritis might look similar in cases, and it is very difficult to order tests for these patients. So here history is very important. The next thing is patient might have granulomatous mass in the orbit causing proptosis, diplopia, and may lead to optic nerve compression. These patients might have BUK, which might be severe and urgent, chronic conjunctivitis, nasolacrimal duct obstruction. So patient might have chronic tearing, retinal vasculitis and uveitis are rare in these patients. Now, this is a case which presented with this suppurative nodule in the sclera, and you see this PUK picture in both the eyes. So initially, this was looking like a fungal scleritis because this patient had history of diabetes and with very poorly controlled diabetes. But on if you do the B scan also, there was uh, detachment in this patient. So patient had both and posterior, but to be positive, and patient was immediately started with high dose steroids and systemic immune suppression, and you see the choroidals have settled, and this is the final picture. Now I will show you the saddle nose deformity. Now you see these two patients, they're obviously not sisters, but you see the saddle nose deformity, which is exactly the same in both patients. So always look for this sign in patients with scleritis, especially necrotizing scleritis. This might indicate an autoimmune disease. And sometimes the vasculitis might be so severe in vaginas, okay, leading to fingertip ulcers. Coming to the next disease, that is relapsing polychondritis, which is a chronic, episodic, multisystem autoimmune disorder characterized by recurrent inflammation of cartilaginous structures, particularly ear, nose, respiratory tract, along with involvement of eyes, joints, and cardiovascular system. So it is extremely rare, only about 3.5 cases per million per year. Peak onset is 40 to 60 years, affects both sexes. It is likely autoimmune reaction to cartilage proteins, results in episodic inflammation and progressive destruction of cartilaginous tissues. Clinical features might involve the ear, the nose, respiratory system, ocular, articular, cardiovascular system, audiovestibular, and skin. So one typical feature is painful red swollen pinna, which spares the earlobe. This is known as cauliflower ear. Patient might have hoarseness and tracheal collapse, which is life-threatening. Coming to the diagnosis, there is no single definitive test. The diagnosis is often based on clinical criteria, excluding other diseases. So McAdam criteria requires more than 3 of the following: bilateral auricular chondritis, so red tender pinna with earlobe spared, nasal chondritis, respiratory tract chondritis, non-erosive inflammatory polyarthritis, ocular inflammation, or audiovestibular damage, that is hearing loss or tinnitus. Lab tests, usually the inflammatory markers are raised. ANA, ANCA, RF are often negative. patient will have normocytic anemia and leukocytosis. So ocular manifestations are important because they occur in about 60% of cases and may indicate systemic disease activity. So all these diseases where ocular involvement indicates systemic disease activity are very important because these have to be referred to the rheumatologist. Now, symptoms due to immune-mediated inflammation of collagen-rich ocular tissue such as sclera, uveal tract, and cornea. So scleritis, episcleritis are common. Uveitis is occasional. Keratitis, conjunctivitis are less common. Proptosis, orbital involvement, and retinal vasculitis are very rare. So scleritis might be diffuse, nodular, or necrotizing and might be vision threatening in these patients. Now, this is a patient with bilateral scleritis. And if you do a careful examination, now you see the ear. The ear is red, tender, and swollen, and it spares the earlobe. So, in these patients, if you do a good systemic examination, you might clinch the diagnosis in the OPD itself. Coming to Behçet's disease, it is a chronic relapsing multisystem vasculitis that affects vessels of all sizes, both arteries and veins, and is characterized by recurrent oral genital ulcers, uveitis, and systemic involvement. It is most common along the Silk Road in ages 20 to 40 years with male predominance, and it has a strong genetic association with HLA-B51. Clinical features, patients might have oral and genital ulcers, uveitis, which might be vision threatening, arthritis, neurobehçets, which is characterized by meningoencephalitis, cranial nerve palsies, psychiatric symptoms, GI tract involvement, where there might be ulcerations in the ileocecal region. So the international study group criteria for the diagnosis of Behçet's disease requires recurrent oral ulceration that is at least 3 times in one 12-month period, plus any 2 of the following: recurrent genital ulceration, eye lesions like anterior uveitis, posterior uveitis, or cells in the vitreous on slit lamp exam, skin lesions, and a positive pathology test. The international criteria for Behçet's disease uses a point-based system. A total of more than 4 points is required for diagnosis. So, ocular involvement occurs in 43 to 72% of patients. The disease is more severe in men. It is bilateral in 80%. Eye involvement is the first presenting manifestation in 10 to 13% patients. Okay, so ophthalmologists play a very important part in Behçet's disease. Time from onset of buccal and genital lesions to ocular involvement is usually 3 to 4 years. It causes non-granulomatous inflammation with necrotizing obliterative vasculitis found in the anterior or posterior segment. The classical finding of iridocyclitis with hypopyon, that is mobile hypopyon, is present only in 19 to 31% of cases. Now, this is a patient with bilateral panuveitis. You see non-granulomatous inflammation and a mobile hypopyon. So if you make the patient lie down and sit up again, you might see the mobile hypopyon. There is vitritis, there are retinal infiltrates, and vasculitis. This is another patient where you see very severe vasculitis in the posterior pole, and this is the Fern pattern leak that you see on fluorescein. And even after treatment, there is severe posterior segment ischemia, and you see these silver wire vessels. Coming to the next disease, that is juvenile idiopathic arthritis. This is the most important cause of uveitis in the pediatric age group. It is a group of autoimmune chronic inflammatory arthritis that begin before the age of 16 and persist for more than 6 weeks with unknown etiology. It was previously known as JRA. It is most common. The peak onset is 1 to 3 years. It is classified into 7 types. Oligo-articular, where less than 4 joints are involved. It is most common, seen in girls. with knee or ankle joint involvement, raised ANA, and there is risk of uveitis. So ophthalmologists play an important part in this. This disease is challenging because the diagnosis is often delayed. So the clinical features, patients might have joint swelling, stiffness, especially in the morning, and decreased range of motion, fever, fatigue, weight loss, salmon pink rash in systemic JIA, and psoriasis in psoriatic JIA, and chronic anterior uveitis, especially in the oligoarticular type JIA with ANA positivity. So, investigations, inflammatory markers are raised. Patients have anemia of chronic disease. ANA is often positive in the oligoarticular type. Rheumatoid factor is positive only in about 5%. Usually, RF positive polyarticular disease and anti-CCP may also be positive in these cases. HLA-B27 is often positive in the enthesitis related type, and this type is often more common in boys. On imaging, there is joint damage, effusion, and synovial thickening. Ocular involvement is most common in the oligoarticular subtype, particularly in ANA positive girls under the age of 7 years. Chronic anterior uveitis is most common and most serious ocular complication. Often it is asymptomatic because the child does not complain and patient do not have ciliary congestion, so parents don't notice, and it may lead to vision loss if undiagnosed and untreated. So the features, redness, as I said, is often absent. Eye pain may be mild or absent. Photophobia can occur if inflammation worsens, and blurred vision may be the first notice sign. Complications are posterior synechiae, cataract, glaucoma, band keratopathy, and vision loss. So, screening recommendations in patients with ANA positivity and articular disease, screening should be done every 3 months. In moderate risk patients, every 6 months, and low risk every 12 months. So, exams should continue even if arthritis is in remission. So, rheumatologists should refer these patients to ophthalmologists. Now, this is a young boy with ANA and HLA-B27 positivity, and this is the enthesitis type of JIA, and you see bilateral hypopyon in this young child. This is another young girl with chronic JIA. You see non-granulomatous KPs and posterior synechiae in a white eye. So, to summarize, ocular inflammation is common and often serious in rheumatological diseases and can involve any part of the eye. Uveitis is a key feature in JIA, ankylosing spondylitis, Behçet's disease. Scleritis and episcleritis are more commonly seen in rheumatoid arthritis and relapsing polychondritis. Dry eye is common in Sjogren, RA, and SLE. Retinal vasculitis and optic nerve involvement occur in SLE, Behçet's GPA, and may cause sudden irreversible vision loss. Regular ophthalmic screening is essential, especially in JIA, and these patients should be treated promptly and aggressively with systemic immunosuppressants or biologics in severe cases to prevent blindness. Thank you.
Thank you, ma'am. Thank you, ma'am, for this very well put lecture. We'll be taking some questions, ma'am. Uh,
Sure.
how do you decide further treatment of the disease when ocular side effects of systemic medications such as hydroxychloroquine or methotrexate occur? Are you there, ma'am?
So, is the question about hydroxychloroquine is not the most essential drug for treating the eye disease. So, if the patient has been diagnosed by the rheumatologist and has been started on hydroxychloroquine, especially suppose in a disease like SLE, so we can always screen for the toxicity. We can do fundus autofluorescence, we can do OCT, and if the patient has hydroxychloroquine toxicity, we can always tell the rheumatologist to give an alternative drug. Nowadays, there are no dearth of rheumatological drugs. We have biologics there, and I think they can be used when there is risk of toxicity with hydroxychloroquine. Hydroxychloroquine per se is given for the systemic disease, not for the eye involvement.
Yeah, so I think that's what they mean, that when it is being given for systemic disease and there are side effects that occur in the eye, so we need to stop that. Then how do we proceed further? So you're trying, so there are alternates that the
Yeah, there
rheumatologist
are
can now
many.
prescribe.
Yeah. So HCQ toxicity was supposed to be a problem in earlier days when there were no alternatives. Now there are many drugs there to treat these diseases. So you can always tell the rheumatologist, and they will put that patient on safer drugs.
Okay. I think this is something that troubles all of us when we are doing our post-graduation, that how do we start with prioritizing the investigations that should be given when a patient comes to us with uveitis, because it is such a huge list of investigations which we need to look into, but that is not always feasible or practical. So is there like a ready reckoner, or there are some things which can be
Yeah.
prioritized over the other?
Yeah, thank you for asking me this question. It's a very good question. See, there is something called as a naming and meshing system. Okay.
Mm.
So, because uveitis is a collection of 30 different diseases,
Right.
when we look at a patient, we have to find out which of the diseases the patient is having systemically. Most of the time, the diagnosis is clinical, but to come to a diagnosis, we have to approach the patient very systematically.
Right.
So, like in history taking, it starts from history taking. So, whether the onset is acute whether the patient is having, accordingly we give a name to the patient. Okay, so suppose patient is having anterior uveitis, so you give a complete name to the patient, that is acute non-granulomatous anterior uveitis with fibrin. Okay,
Okay.
so this is the complete name. Now with
Mm.
this complete name, what are the differential diagnoses you can think of? That is called
Mm.
meshing. So,
Okay.
thinking of differential diagnosis is nothing but referring to the published literature. So,
Mm.
acute non-granulomatous unilateral anterior uveitis with fibrin is usually due to HLA-B27 positivity. So, what test will you do? Complete blood count, CRP, HLA-B27 by PCR, and X-ray of the sacroiliac joints. So now in this case, you will not do Montox. If the patient is having chronic unilateral granulomatous anterior uveitis with Basaka nodules with peripheral anterior synechia, okay,
Mm.
and posterior synechia, then
Mm.
you have to look for tuberculosis, sarcoidosis. So in this case, you will not do tests for HLA-B27 or X-ray cell. So this is called the naming and meshing system.
Okay.
90% of the problem is solved when you give the complete name to the
Name.
patient.
Right.
Okay, if you just write anterior uveitis or if you just write intermediate uveitis, then the problem starts. So when you, so basically you have to do a mindful clinical examination, and whatever you it should come in a complete name. And then you can think, okay, these are for the etiological diagnosis, you have to note down the differential diagnosis in your mind. Those tests you have to do. So for every patient, we should do complete blood count, CRP, and TPHA. That is to rule patient, and rest depends on the clinical picture.
I
I
think, ma'am,
hope
some
I
part.
answered.
Yeah, I think some part of what you were saying got chopped out because of network issues. Could you just repeat the part where you said some tests which should be done in all the patients, irrespective of what we are
Yes.
thinking?
So complete blood count, C-reactive protein. Okay, C-reactive protein is a more specific marker of inflammation compared to ESR.
Yes.
Okay, so complete blood count, CRP, and TPHA to rule
Okay.
out syphilis.
All right. So this
So
should be done border if baseline for all the patients.
yes, for all that. That is what I practice. I do this for all the patients. Rest everything depends on the differential diagnosis.
Yes. Okay,
Yes.
ma'am. Ma'am, I think these are questions coming from postgraduates while from their own experience as PGs. So they're saying which immunomodulators or immune sparing agents are easily accessible and affordable for patients coming to government hospitals, which they can prescribe really in their day-to-day OPDs.
See, if you have experience in prescribing these drugs and you can monitor them and look for toxicity, then the most common drug, which is very safe, is methotrexate. So, methotrexate can be prescribed for many of these autoimmune diseases, and you can actually monitor the complete blood count, SGPT, liver enzymes, and serum creatinine. And but it is always advisable to have a rheumatology friend who can, especially if you are not trained in uveitis, it is always better to take help from the rheumatologist.
Okay. Ma'am, that brings me to another question related to this, which is once we have reached a diagnosis of a systemic disease, is it
Hmm.
more practical to let a rheumatologist or immunologist take over the treatment to manage systemic immunosuppression and thereafter immunomodulation and immune sparing agents and all the other treatment? Or is it still primarily managed by an ophthalmologist or a uveitis specialist?
As I will tell you, because of my training in Ireland, where I learned how to prescribe these drugs, even biologics, I generally prescribe my own treatment. I send to the rheumatologist only when the disease has the systemic features are more than the eye problem. Okay, so sometimes patients with HLA-B27, for example, I always send these patients to the rheumatologist. But if the patient has ocular TB, or maybe a localized disease, like, then I might treat on my own. So it all depends on your training and whether you can confidently monitor these patients. So if you have completed a uveitis fellowship and you are confident and you have worked under somebody for some time, and you are experienced in prescribing these drugs, there is no harm. It's not difficult to monitor. Uh, but if you feel that you need some experience, it is better to work with a rheumatologist so that patient is benefited.
No, got it. Uh, Ma'am, there's a question. How do we manage steroid responders?
Yes. So I presume they are talking about topical steroids or
Yeah, yeah. Yes, ma'am.
local steroids.
Yes, ma'am.
Here again, you can manage these patients with anti-glaucoma drugs. If if the intraocular pressure is not very high, you can manage on your own. If there is iris bombay, you can do a PI. But for if you are using the steroid drops or the local injections again and again, I think it is better to go for systemic immunosuppression. And if the IOP is consistently high, you can refer to the glaucoma specialist and see if any surgical intervention is required. So I think it is better not to repeatedly use topical or systemic steroids. If you are using repeatedly steroids, that means the disease is not under control, and every episode of uveitis will cause some damage to the eye, and the final visual prognosis will be affected. So it is good. It is not good to keep prescribing steroids again and again. And I think if the intraocular pressure increases severe, they should be referred to the glaucoma specialist and work with them.
Uh, there's another related question, ma'am. How do you decide when to escalate from topical to systemic immunosuppression in cases of ocular inflammation? So, like you suggested, one of those indications would be steroid responders. What are the other indications, ma'am, where we would escalate from topical to systemic?
See, like I said, if the in HLA-B27 related uveitis, the recurrences are zero point 0.6 to 3.3 per person per year. So if the patient is having more than 3 episodes per year, patient should be put on systemic treatment. If the patient has SPA, then from the first episode itself, patient should be on systemic treatment. See, any autoimmune disease with a confirmed systemic association should be treated with systemic immune suppression at the first go. We should not wait for the patient to develop complications. Like the patient with rheumatoid arthritis and there was PUK with corneal perforation. So the patient should not go to that stage. Okay. So any disease association, systemic disease association, patient should be started on systemic treatment immediately.
And ma'am, in case we do not reach a conclusive definitive diagnosis systemically and it is confined to the eye, then when is the need to escalate to from ocular to
No,
topical?
no, no, without, yeah. So without knowing the cause, it is not advisable to start the patient on systemic because you will not know what you are treating. Uh, Sometimes some diseases like sarcoidosis might present in the eye first. Okay,
Right.
and in these patients also you can start systemic immune suppression because after the second or second set of steroids systemic steroids is not good to continue beyond that because patients will get cataract and the other complications of steroids. So immunosuppression should be started as early as possible. So try to make a diagnosis as early as possible and then treat the patient with specific drugs.
Okay. Ma'am, we'll take one last question in interest of time. How
Yeah.
do ocular manifestations correlate with systemic disease activity, and can they serve as reliable biomarkers for disease control?
Yeah, so as I said in my talk, scleritis in a patient with SLE or scleritis in a patient with rheumatoid arthritis suggests that the patient is having severe systemic disease. In case of ankylosing spondylitis, uh, acute anterior uveitis might precede and activation of systemic disease. So for every disease, it is different. Okay, it is not the same for all diseases.
All right. Okay, ma'am. Thank you so much for this very well articulated class. I'm sure that a lot of postgraduates are going to be able to implement it in their everyday OPD practice. And for our other viewers, our next class would be on 11th of June, Eye in Central Nervous System Diseases by Dr. Rashmin Gandhi. We'll see you then. Thank you so much, ma'am, again. Bye-bye.
Thank you for having me. Thank you.
Yes,
Bye.
ma'am. Thank you. Bye.